Good morning, afternoon, everyone. Hopefully you can hear me okay. I'm Katie Pierson. I'm going to be doing this presentation today, and I'm just so excited to be here. Thank you so much, Surge Logs. And without further ado, I'm going to go ahead. Okay, so y'all can see my slides. You can hear me okay. So I think, here we go. My name is Katie Pierson. I am a nurse educator. I'm a regulatory specialist currently with Ambulatory Healthcare Strategies. I have about 20 years of nursing experience, which is just always so crazy when I say that out loud, but time just keeps ticking, huh? And throughout my career, I've worked with healthcare systems, hospitals, ASCs, most recently within the past 10 years. And I'm really passionate about helping folks develop their policies, tackling those infection control challenges, and just really trying to help make it all manageable, which I know always sounds like an impossible feat, but I do my best because I'm very passionate about this. And really what we do at Ambulatory Healthcare Strategies is just try to help bridge that disconnect as best as humanly possible through accreditation preparation, again, lots of infection prevention and operational support. So you all don't have to, I'm not going to do a formal poll unless that's being done, but I'm just curious real quick, which accrediting organization do you currently use? Is it AAA, Joint Commission, Quad A? You can even write in ACHC if you use them, or DNV. I just kind of want to get an idea as to the people we have here today. Okay, CMS. I guess I should have mentioned them separately. SSS, AAA. Okay. Oh, we do have some Quad A too. Okay, yep. Awesome. So I don't think the DNV accreditation for ASCs has actually formally gone into play yet, but I know that's been something that they are doing, and they are talking about pushing that through. So we're learning the standards over at AHS for sure, but looks like we have a good eclectic mix through all the accrediting agencies. And the nice thing is that today's conversation, I'm really going to help or try to speak about each of, all of them. All of this is applicable to any accrediting agency or even CMS. If you have to follow a rule, that's what we're going to be talking about today. So let's go ahead and talk about the rules and kind of what happens. So starting off with, how do we make this happen? And I'm going to start off with a quick little story. So a surgery center has a accrediting agency or CMS come through for the survey. And this probably sounds familiar, where the policy manual looks flawless. If you're type A like myself, you have all those tabs, all the signatures look really good, everything has the right dates, the right times, everything's in perfect order. And then the surveyor comes through and within 5 minutes they see, a phone sitting on a desk somewhere in the OR, a rush timeout happen, and then at least 3 missing signatures on a temperature log. And then they say, okay, well, thank you. Now, how do you make what's in your policy manual actually happen in real life? And that one sentence, I think, really sums it up perfectly. Compliance, although it might feel like it, isn't about what's written. It's about what's lived. Surveyors and our patients, they really care about, what happens when nobody's watching. And if there's one takeaway from this session today, it's this. And that is that your documentation and implementation need to be inseparable. When those two drift apart, that's really when citations, inefficiencies, and safety risks really creep in. So let's talk a little bit about why those disconnects happen and what we can do to close them. Really across 2024 and 2025, infection control and documentation continue, not beginning, but continue to be those top 2 areas of deficiency for ASCs nationwide. And that's not because people don't know the standards. We all know what we're supposed to do. Of course, there's that bucket of folks that are just learning and don't know everything yet, and that's perfectly fine. But a lot of people, they know what to do, but it's because that consistency breaks. You can have a flawless sterilization policy and still run into trouble if a single load record is missing on a chemical indicator or a biological test isn't signed off before the next load runs, right? It's not about being bad, one day. It's not about one bad day, excuse me. It's about the patterns that tell surveyors that your process isn't being consistently verified or done. So when CMS, AAA, TJC walk in, they aren't just asking, do you have a policy on this? Yes, that's one component of this. But they're also asking then, can you show me what's written? Is that, that's what's happening every single day. Survey readiness in 2025 isn't about the perfect manual, although that is helpful to have a really good looking manual and to have everything that you need in there. It's about living the standard daily, because when staff behavior, documentation, and policy all tell the same story, surveys go a lot smoother, and trust grows with your patients, with your team, and with those surveyors, right? So before we dive into the examples, I am going to just disclose, what we're going to talk about today and what hopefully you'll take away. First is that we'll identify the most common disconnects between what's written in your policies and what actually happens in daily practice. Things like surgical attire, timeouts, documentation, and credentialing. Those are kind of the big buckets that we often see. Secondly, we'll explore why these gaps happen. It's rarely, again, about that lack of knowledge. It's usually about blind spots, workplace friction, or leadership assumptions that policies automatically equal compliance. Next, we'll talk about how to use your QAPI program as a true bridge for improvement. QAPI was designed to connect the data to action, not just fill a binder with meeting minutes and graphs and all that nice looking stuff that you have in there. Fourth, we'll talk about how technology can reduce your compliance burden instead of adding to it, including automation, real-time dashboards, and the way digital tools are helping ASC stay consistent. And finally, we'll close with some of the most recent updates that impact things like infection control, pharmaceutical management, credentialing, and daily readiness. So by the end of this, I'm really hoping that you'll have some key takeaways and maybe a few ideas that you can start implementing tomorrow. Okay, so let's get real about what this looks like in daily life. Most of our policies, again, read beautifully. They're well organized, they're clearly written, and often built right from best practice standards or the local hospital that you got it from. But once you step into that OR or pre-op area, reality can look a little different, right? So for example, your policy says, perform a full surgical timeout before the incision. What happens in reality? For some facilities, I'm not saying yours particularly, of course, the surgeon is scrubbed, anesthesia is ready to go, and that pause for safety really just turns into a rapid fire checklist, something that we just have to get done. Everyone's focused on starting the case and not documenting the discussion. And what's wild is this literally just came up in a meeting this morning at my company, where they knew that, they called it out, and the circulating nurse just could not stop. Like, they just had to keep going, had to keep getting ready, had to keep doing things. And they said, okay, but on survey day, if you could just stop, that would be great. But what happens when you get to survey day and it's not already embedded in your culture? I think many of us have felt this before. They got cited on it because she couldn't change her practice for just one single day, right? Another example, your policy says all staff must wear facility laundered scrubs and no personal items. And this is why it's really, really important to know what is in your policy, because it says that, which AORN aligns with that. Then, you walk in and you see someone with their smartwatch on, that's a personal item, or their cell phone on the desk, or that badge reel that's, personal to them. Be very mindful of what's in your policy and then what's actually getting practiced out there in the real world, excuse me. I will say too, for AORN standards, they're great to follow. They're best practice, they're evidence-based, it's great research. However, if the standard doesn't say that you have to follow a nationally recognized guideline on something, and then you just blanket say that we follow ARN, that's an area where a lot of people get into trouble because they don't think about all of the ARN standards that then they have to abide by. So you can pick and choose which ARN standards that or guidelines that you're choosing to follow. And you really want to make sure, of course, that it's catered to your specific facility practice. And then, another one, documenting every consent verification. Of course, that is something we're going to do. That is a requirement that your consent is verified. And it's very simple to write down on paper that you're going to do that. But there's a busy day. You have 2 really quick turnovers, a late patient, a physician that might not be super happy about things, and those final initials might get missed, right? And these are the small disconnects that surveyors catch instantly. They don't just see a misstep, they see a system that isn't self-checking. And what prompts deeper digging then, right? I don't know how many of you have been through a survey, but as soon as they see one thing like that, then they just keep going down the rabbit hole and seeing what else they can find around there. And it's rarely the big things that centers get cited on. It's those small, repeated lapses that seem harmless, but really reveal that culture. So a couple of case scenarios that have come up too. Surgical attire. I'm going to probably, beat this one till it's a dead horse here, but policy says that they require disposable caps, again, to align with those ARN standards, because that's what ARN says. But then the staff are wearing their cute, like really nice holiday maybe or personal caps that they've been wearing for years, right? We've always done it that way, but that's how it's always been done. No one has ever said anything. No surveyor has ever come in and told us any differently. So I'm going to keep wearing my cap. I understand that. And you say in your policy that you follow the AORN standards. New surveyor that's fresh out of survey school comes in and wants to follow every single solitary thing to the T because that's what they think they've been hired to do. And I'm not arguing with that. But, even if you've never been caught on it before, doesn't mean that you're not going to be caught on it later on. And basically now you're saying you do one thing, but you're actually doing something different, right? So now you have an infection control citation for failure to follow your written policy. Another one we see come up, the policy says that the circulating nurse is going to verify the document, to verify and document consent and that site marking before the patient enters the OR. I've seen this a number of times where the OR nurse goes out, they speak to the patient, they make sure everything's been done, everything's been signed off. But I've seen 2 instances now where they either go back to the OR and then they get distracted, they move on to that next piece of paper, especially when paper documentation is involved. If you're not checking that you've done everything that's required on that piece of paper before you move on to the next one, you can miss that documentation. Or I've seen it, and I should say that checkbox never existed. So they did the work. They did a gorgeous, verification of that site marking, but there wasn't actually anything on the documentation to say, that work had been done. So when the surveyors reviewed the chart, there was no proof. And then this last one here. So the policy required that the governing board approved privileges, right? Because that's how that process usually goes. But then what happened is that the medical director had signed off on his own privileges, thinking, what, I'm the medical director. I can just sign off on myself. Well, when the governing board is who's responsible, and then the medical director who's signing off on themselves, that's a disconnect right there too, right? And that's not just a technical issue, it's a governance failure, really. So surveyors, they don't judge intentions. They know you're usually trying to do the right thing, but they do judge alignment. So update policies to match the compliant practice or retrain to meet your written standards, because that middle ground is really where things get cited. And I just want to emphasize that these disconnects, again, they don't happen because of bad staff most of the time. They happen because we assume the work ends when the policy is written And in reality, that's when the work begins. So why do these disconnects keep happening? And it's rarely because people don't care. It's because the system doesn't make the right thing the easy thing. Staffing pressure is probably the biggest reason I've seen today. When you're short staffed or overloaded, what happens is shortcuts, right? We all just try to get the work done as best and as fast as we can. And then that becomes survival mode. And then over time, that survival mode just becomes the new normal. So when people tell me that we've always been doing it this way, I sometimes question, but when did it start to become that way? And a lot of times it's because they had a leadership turnover or a ton of staff turnover or something like that. Outdated policies are another. People will write these beautiful policies, make sure they're updated, and then they won't look at them again, or they don't have time to look at them again. I'm not saying this is intentional. I'm just saying that it just doesn't happen. And your processes typically evolve faster than the paper. And then your staff improvise, and then that manual no longer reflects reality, right? Peer-to-peer training plays a role too. I think we can all attest to this in the ASC industry. We, make do with what we have when it comes to training and getting everybody on board with everything as fast as humanly possible. So new hires now learn the habits that were embedded by the staff that's training them. They're not necessarily sitting there reading all of your beautifully written policies, even though they say that they've received them. And then that's how tribal knowledge is spread, right? So practice is passed down instead of that policy really being reinforced. And finally, those leadership assumptions. We assume that if it's written, then it's just happening. But unless you do walk that process yourself from pre-op to recovery, you may be surprised as to how much actually gets shifted. And especially when your staff is not fully on board with a standard or a process or a practice, they will do what they think is best to make that work. And of course, the trouble there is not only not doing what you've asked them to do, but now it's not matching what the policy actually says. And keep in mind too, this is not a failure on anyone's part in particular. It's just an opportunity. So once you see that that process has drifted, you can fix it intentionally instead of hopefully reactively. Okay, so let's talk about how to close the gap. QAPI, also known as your Quality Assessment and Performance Improvement Program, is meant to be that bridge between what is written and what is practiced. I really try to emphasize this as much as I can when I'm talking to my clients, that QAPI, it's not just what's in your binders. It's not just a pretty graph. Your policy should define what should happen, right? Your practice shows how it does happen. Then QAPI connects those two and measures whether or not those two are aligned. And when done well, QAPI tests your systems. It asks, is this process working for the staff and the patients? And if not, what needs to change? Right? We talk about it all the time. We talk about performance improvement projects or quality studies. That is your opportunity to see if there's disconnects between your practice and your policies. But again, too often, our QAPI binder just becomes an exercise. Lots of good data in there, lots of printed graphs, lots of meeting minutes that just gets shoved in a binder up in a shelf until your next survey. They don't want to see that you've tracked a metric, the surveyors. They want to see that you've actually acted upon it. If your audit shows that you're 80% in compliance with something, your QAPI team should be saying, why not 100? What's getting in the way? What's happening that's not allowing us to get to that 100% mark? Then we act on it, right? We try to do something to improve it. Then we'll remeasure it to see if that's worked. And really, that's how QAPI moves from just being paperwork to being a process and progress really over time. Okay, but I do have to mention that QAPI really only works if leadership closes the loop. When the same issue shows up quarter after quarter, that's not a staff problem anymore. That's an oversight signal. If I see one more time, we'll continue to track and trend when you have an ongoing issue, I'm going to scream. Every accreditor, AAA, Quad A, ACHC, TJC, DNV, even, they expect the governing body to act on that QAPI data. Reviewing the minutes is not enough. You can't just be, yep, we reviewed what they've said and we agree with everything that they say. And if you're agreeing that there's just this ongoing problem again and again, if you have a surveyor that knows to look for that, it's going to lead to a citation. So leadership should be able to show what issues were identified, what actions were taken, and then what were the outcomes of those actual, what were the outcomes of those results, or what were the results of those outcomes, excuse me. In 2025, I've been hearing a lot more that the surveyors are actually asking, governing body, how are they using the QAPI data to make decisions? And I hope that some of you have an answer to that, because that's where the conversation is getting driven now. Closing the loop, it can really change your culture, right? Because staff see QAPI as a compliance audit, right? And now they can start seeing it as a shared improvement tool. Leadership can provide the resources, staff can provide the feedback, and kumbaya, together now you're fixing the processes instead of just, tell me what you guys think is wrong. I'm going to go write it over here. Here's what we're going to do to fix it. Oh, it's not getting fixed. Trying to make it more of a team effort, a collaborative approach, because I think we can all attest that if you get that staff buy-in, you get them more involved in the QAPI process, you're going to get better sustainability over time. So here's what it can look like in real life. We had one ASC, they did some audits of their sterilization logs and saw that 85% of their documentation was being done for their biological tests. So 85%, oh my gosh, that looks so good, 85%. But that meant that 15% of the loads had either missing or unsigned data. That means 15% of the time now you're opening yourselves up for an infection risk, right? So instead of blaming the staff, why are you not just doing this? The team used QAPI to dig deeper. The root cause wasn't the training. It wasn't, again, that they didn't know, because like I said earlier, a lot of times people know what they're supposed to do, but there's typically two reasons why people don't. I'm going to go off into a quick tangent here. Two reasons why people don't do things. It's either they're not able to, or they're not willing to, right? It's either it's not easy for them or it's not motivating for them. So if you can dig into those reasons a little bit more, you might be able to get down into the root cause. So for these guys, it was that where they were documenting everything was completely on the opposite side of the wall in a completely different room from when they were actually performing the task. So when they realized that, they said, oh, let's actually move these logs, move everything to a closer location to where we're doing everything. Then next quarter, compliance was now at 100%. So it wasn't a willing problem. It was they weren't able to because it wasn't at front of mind, right? It wasn't easy for them to be able to do it. And that's what surveyors want to see. They want to see that awareness. They want to see that action. And then they want to see that remeasurement. And, it's not about being perfect, but it's about, what can we do to get there? What are we doing? Are we doing everything we can to get to that 100% and showing what we're doing to get there? Okay, so let's talk about closing some of those gaps. The ASCs that I've seen that are survey ready every day, which I know sounds like a ivory tower thing, but I promise you it is possible. They share four very common habits. The first is they conduct monthly environmental rounds, and it's not always done by the same person. It's not always done at the same time. It's not always done at the same day. It's about having someone, preferably from leadership and staff, actually walk around and walking the space like you're a surveyor, and catching those small issues before they grow into something bigger. Secondly, they perform peer audits. So again, it's not just the administrator or director of nursing or somebody in the back corner filling everything out to get it all done. It's having staff audit each other. because with that, you can notice, trends. They notice details that leadership may miss. And now it builds a shared ownership of compliance amongst the staff. Third, they hold quarterly policy reality checks. Each quarter, just pick a handful of policies. It doesn't have to be a whole bunch. It doesn't have to be an entire chapter of your accrediting agency. Just pick a couple and say, do these reflect what we actually do? Because that's a very quick way too. I've seen it so many times where eye centers, I don't know how many of y'all are eye centers. I should have asked specialties too in the beginning here, but I've seen eye centers talk about packing sponges. And I mean, unless something happens, I don't see a lot of packing sponges being counted in an eye center. So make sure that your policies are actually reflecting the specialties and the work that you're doing. And finally, they run scenario-based drills. And I don't know if this sounds silly to you, but there's many centers that just do the tabletop, even though you're supposed to do a full drill every year, specifically when it comes to emergency preparedness. But run that full drill. Do the full scenario for your fire drills, for your MH. Even I've seen people do a drill for med errors where you're really trying to capture what happens if this occurs. Do we have the right supplies? Do we have the right logs in the right place? So that gives them that real practice to perform, what's actually needs to happen and what's going on, instead of just theoretically talking about, oh, here's what we would do. And that really helps showcase some of those things that might be missing, or processes that just won't work out, even though your policy says this is exactly what we should do. Okay, so where does technology help here? It's 2025. I can't believe that, by the way. And, technology is here. It's here to stay. And yes, not all technology is made the same. But what it should do is it should make your compliance easier, not more complicated. Policy alerts are out there. Credentialing expirations can be told. QAPI deadlines can be automated. You can get digital logs to allow for that same day visibility. If you're going to embark on compliance software and you don't know where to start, right? Because there's tons of things that technology can do for you. I would say shifting from paper to electronic logs is probably one area I would highly recommend, because then your logs become part of your culture instead of just a piece of paper that's over here. You're able to see in real time what has been done, what hasn't been done, what trends are we seeing. A lot of them have those expiration dates that you can set, and then you get a reminder that there is an expiration date or that a log does need to be done, so you're not having to wait till the end of the month to catch that something hasn't been done. I've seen it where your crash cart has to be checked, right? So if not done by a certain time, you get told that crash cart needs to still be checked. I promise you, technology can work really great in getting all of the work done. There's a couple search logs, obviously, does a really good job at it as well. And just helping you get that early warning system, helping highlight those trends before you get findings, because the right tools that fit into your workflow, they'll help your staff, not by memory, but by design. And that's really how technology can turn compliance from a burden into a built-in safety net for you. Because let's be honest, that's what this is really about, right? The rules and regs and standards are not there to make your lives miserable, even though some days it might feel that way. It's there to help keep your patients safe, to keep your staff safe, to keep your physicians safe. And so, whatever we can do to help make that happen, I'm all for it. So definitely highly encourage that. If you haven't checked them out, this is obviously sponsored by SurgeLogs. Definitely check it out. They have a really cool policy that matches to the accrediting agency's standards to make that easy. Steve loves technology too from SurgeLogs. But they really do try to make it so you don't have to think so much about what do I need to get done. It's helping you figure that out for you instead of spending hours and hours on checklists kind of thing. So definitely check it out. Okay. So one center I worked with, just to really emphasize this too, so they kept missing their crash cart log checks. I mean, at the end of every month, what do we typically see is, oh no, we have this day, and this day missing. Who was here that day? Let's just go ahead and fill it in because somebody was here that day. And I mean, it was still working the next day, right? So obviously we can just fill that in. I know no one here on this webinar has done that, but unfortunately I have seen that practice before. Or in the event of a survey, they'll find it and then you have to answer for that. So I have seen it happen at least 6 times now where they move to digital logs and now they have 0 misses. And it's because it has made it easier for them. It tells you when you need to fill it out, when the center is closed. It assigns it to certain staff members and not just one staff member, right? Because, Jane is on vacation and she's the one that has always done our crash cart log for us because she's the only OR nurse. Well, the systems can tell you, okay, Jane didn't fill it out, so now Georgina needs to do it. So just, keep that in mind because I've seen it where now they have 0 missed crash cart log checks, which to me, I really want to make sure that crash cart is functional, operational, and checked before you do my surgery. I might be that crazy patient that will say, did y'all check your crash cart today? Because although we don't anticipate anything happening, I know I'm in an ASC because I know too much now, right? We're the worst patients. Nurses, ASC leaders, we become the worst patients because now we know better, right? So I'm going to want to know that crash cart check was done. And, another center I've seen this happen well with is with those policy reviews, because again, you kind of let time go by too long before you've checked it again or reviewed it again. But with systems like SurgeLogs, you can set that date, that reminder date of, hey, it's been, almost a year now since you've last reviewed this policy. Let's make sure that it's up to date. So, I've seen compliance improve. That staff stress just drops because they're no longer getting yelled at for not doing what they're supposed to be doing, and you're doing the right thing. And then your survey prep cuts as well dramatically when you do get into technology. That's its role. It supports your people. It doesn't replace them. And I'm not going to get off into my technology tangent because I can definitely get into that more, but just keep that in mind. Okay. So, quick question for you all. Just wondering where you kind of lie. Where do you think, and it doesn't even have to be one of these 4 answers, I just kind of gave some examples, but where do you see that your policy and your practice drift the most? Where do you see it where there's like the biggest disconnect between what's written in your policies and what's actually happening in practice? If you know, if you don't, that's fine too. You can take a guess. You don't have to type anything. That's fine too. But I'm just really curious, where do you think, like, you have this written down, but this is actually what's happening? I'll give you 30 seconds just in case you're sitting there trying to type up an entire paragraph for me, because okay, I'm seeing a lot of documentation related responses here. Yeah, you're not alone. Although attire, I would say, is number 2. If your attire policy is super strict and then you have a staff that has just decided to go and do what they want to do with attire, I've that one I feel like comes into a close second. But yes, those documentation and logs, you're not alone. Just know that is the majority of the answers here, because those 2 areas, they rely most on human consistency, right? Which means small process tweaks and the right automation can make the biggest difference. So keep that in mind as we move into what's happening in 2025, because those are the exact areas that are getting the most attention. The doc's attire, preach on that one. I had a doctor who insisted on wearing his cowboy boots in the OR every day, and not covered, because I'm not going to cover my gorgeous cowboy boots. I'm in Texas, so apparently that is a thing. And I appreciate, as an administrator, you have to pick and choose your battles. That was one I hadn't come across yet, so I can appreciate that one. Or they're running from the hospital and they're like, "What? I'm just still in my scrubs." And you're like, "Ooh, yeah, but you just brought everything from that hospital and outside now into ROR." So I can definitely appreciate that one. Okay, so let's talk about what has happened in 2025. Across every accreditor, the theme is alignment. Policy and practice must match every day, not just at survey time. So the ARN, who I've talked about extensively today, has updated its surgical attire guidance. Personal items, phones, lanyards, jewelry are now explicitly listed as contamination risks. So if you say that you follow the AORN guidelines and you haven't yet purchased the most updated version, I highly recommend you do so and start reading them at length and making sure that you're doing what you say you're doing and what's in your policy. AAAHC is emphasizing infection control and pharmaceutical management integration into your QAPI. You need to show how does that data drive improvement, not just that you're monitoring it. Quad A has really tightened their governance standards, requiring independent privilege reviews, so self-approvals are no longer acceptable. ACHC is focusing on ongoing competency validation, not just the initial training that happens. TJC is really pushing daily readiness with live staff interviews and scenario-based drills. The DNV, as we've been reading more about those, is moving towards data-driven surveys that prioritize those metrics and outcomes over the manuals. So they're going to say, that's nice, but let's look at the actual data. And if you're familiar at all with the ISO 9000, that kind of drives what DNV does. That's where they're getting it from. I'm not hearing a lot of centers electively choosing to go to DNV. I think it's if your hospital, I think, is participating with it, or if you are wanting to elect in an annual survey, because that's what they do. They come to your center every year and do a survey. That's where I'm seeing people choose the DNV. Just letting you know, in case you're wondering what's the biggest difference there. And then if your ASC is already performing regular rounds, peer audits, and QAPI cycles, just know that you are ahead of the game. But I wanted to kind of give you that information and know what's going on there. So here's the big picture. Policies set the expectations. Practice reveals what's going on in your culture, and then that proof will sustain the compliance. QAPI then is what? It's your bridge that connects what's written to what's real. And then technology is really your safety net that keeps it consistent. When those three elements, policy, practice, and proof, work together, your ASC doesn't just pass surveys, it thrives between them. So what I'm trying to challenge you all with, maybe just one little challenge. Tomorrow, today, whenever you get a moment, I would actually say maybe right this second while you're sitting here in this webinar, because I know as soon as we leave, we're going to go back to reality. Pick one policy, walk it from start to finish. And, I would just go to your surgery area policies and just choose one. See where that paper version doesn't quite match, or electronic version doesn't quite match reality. And instead of just updating that policy, I would also challenge you to turn it into a QAPI project. Think about it. Does it need to change? Does the practice need to change? Is who we refer to need to change? Because that's how you move from reactive compliance to a proactive culture. Just one policy at a time. Okay. Okay. Well, thank you so much for joining me today for this webinar. I hope I gave you some tips, tricks information that you'll look at your policies, you'll look at your operations with fresher eyes. Compliance doesn't have to feel chaotic. When policy practice and proof align again, it really becomes of how your team will just naturally operate. And a huge thanks to SurgeLogs for sponsoring this session and supporting this. And I really wish all of you ASCs the best of luck out there. If you have any questions, go ahead and drop them into the chat. But if you don't, if you're like, peace, Katie, I'm going to go read all my policies right now, totally understandable. My email address is there. My phone number is there. Please, please, please don't hesitate to reach out. We're here to help you navigate this insane world, but exciting and fun one as well. So thank you, everyone. I really appreciate you. Thank you, everybody. All right, I'll give you all like 2 more minutes, see if there's any questions. Thank you. No questions. All right, I'll give it 1 more minute. There might be somebody that's like typing up an entire novel, and I would hate for them to hit enter and me not be here. So I'll just wait 1 more minute. Hopefully everyone captured my email address if they really had an egregious problem that they need to talk about. All right, everyone. I'm going to go ahead and end the broadcast. Thank you so much. Bye.